Thank you everyone for joining. This is the second Rover 2.0 for residents. Today we're doing genitourinary malignancies. And we have our panelists. We'll have each one of them introduce themselves. So we can start with Dr. Vapawala.
Yes, hi, Jenna, and thank you everyone to the organizers for having us here, and hi everyone for joining today. It's exciting to be able to have this hour together under these strange circumstances, but making the most of it by being able to gather in a way that we wouldn't normally. For those of you that may not know, I'm a professor and vice chair of education in the Department of Radiation Oncology at University of Pennsylvania, and my clinical specialty is GU cancer. So happy to be here. Thank you.
Dr. Tward.
Yes, thank you again for the invitation. I hope we have some fun here. I am a professor of radiation oncology at the Huntsman Cancer Institute at the University of Utah, pretty much exclusively doing genitourinary malignancies.
Wonderful. Looks like Dr. Wen came on just in time. Looks like he has a pretty background too.
Hi.
We're just introducing ourselves. Maybe he's
fantastic. So yeah, so I'm Paul Nguyen, radiation oncologist at Dana-Farber Brigham Women's Cancer Center. I focus on GU malignancies, and sorry for my troubles getting onto Zoom, but I'm really excited to be here today.
We're jealous that you're at the beach. And next will be Dr. Solanki.
Hey, I'm Abhi Solanki. I'm not at the beach, but even a better place, Hines VA Hospital in our clinic. So wouldn't trade the beach for that. I'm one of the radiation oncologists here, the primary GU person. And about 80-90% of what I do is GU. And then I also treat CNS and excited to be here.
Wonderful. So today we have 4 different cases. Just a couple things, groundkeeping. The chat, if you have a question, change the chat feature to all panelists and attendees so everyone knows what your question is, and we'll try and answer those throughout the cases. So with that, we'll start with our first case. Dr. Vapawala, do you want to start with your case?
Sure, sounds great, thanks. So this is patient MK, 66-year-old gentleman, and his initial presentation was unfortunately to the emergency department with complaints of suprapubic and penile pain, decreased urinary frequency, and dysuria. So as is often the case in the emergency department, we went right to a workup to establish potential etiology. So this included basic metabolic panel and analysis of his urine. And really the only notable finding there was just an elevated creatinine. And so a CT abdomen pelvis obtained in the ED showed extensive lymph node metastases. What was concerning for lytic metastatic lesions in the L1 and T12 vertebral bodies, again, no known history of cancer in this patient. And then also noted was an indeterminate liver lesion and some lung nodules at the lung bases. So the reading at the time was that these imaging findings were most consistent with a bladder cancer. So as you all know, we certainly still want to speak to the patient and get, all the detailed background here. So as you can see here, his past medical histories, often very commonly seen in this age group, hypertension, hyperlipidemia. He did have a history of stroke and the past surgical history. I apologize, that shouldn't be there. That was supposed to be the animation I took away, but surprise, it's gonna be prostate cancer. Okay, so past surgical history was non-contributory other than the items that are coming up, and we'll talk about those in a little bit. Social history, he's married, he quit his tobacco use over 20 years ago and denies alcohol use, and no family history of prostate cancer. So next slide. So because of the concern about a bladder cancer on the original CT from the emergency department, he did undergo cystoscopy with biopsies. And at the attempt, as the attempt was made, unfortunately, the resectoscope could not make it past the prostate. And it was noted that there was also a very high bladder neck. So at the time, they also attempted to place a wire through the urethra to see if that might assist. But again, this was unsuccessful in being able to complete the cystoscopy. So that was aborted, and a cystourethropy was performed instead with a flexible cystoscope, and again, confirmed that the bladder outlet was severely occluded and that there was a mound of tissue at the bladder neck extending into the bladder lumen. And at this juncture, because of this finding at the time of attempted cystoscopy, there was also concern for prostate cancer, which again, previously had not been the case. And PSA, which again was attributed to his acute obstruction, was highly elevated at 547, but the decision was made certainly to not only perform the bladder biopsies, but also a prostate needle biopsy. Next slide. And these are the findings from his biopsy. As you can see here, high-grade disease, Gleason score 8 in 1 out of 5 cores, and bilateral disease on the left. He was noted to have Gleason score grade group 2. Interestingly enough, and I didn't elaborate on all the findings from the cystoscopy, but you have to take my word for it that there was no evidence found of bladder cancer on the cystoscopic evaluation. So in light of the various findings from the emergency department, additional workup was done, CT chest, and again, those small pulmonary nodules were noted in this former smoker who had quit 20 years ago, thought to be potentially metastatic. Also seen were the multi-level lytic metastases in the thoracic spine and this enlarged mediastinal lymph node, which was considered potentially metastatic. On bone scan, there was only seen uptake in the left ischium, suspicious for osteoblastic metastases, but none in those lytic lesions that were seen in the prior CT chest. Sorry, this just popped up on my screen. And an ultrasound of the retroperitoneum was also done given the severe obstruction that this patient presented with. And he was noted to have moderate right-sided hydrouterine nephrosis. Again, the diagnosis from the radiologist was secondary to malignant invasion of the urinary bladder in the setting of the known biopsy-proven prostate cancer as of the time of this retroperitoneal ultrasound. Also noted was a lower quadrant hypoechoic mass consistent with or concerning for metastatic lymphadenopathy. So if I told you right now to ignore the CT chest for the moment, given no clear diagnosis there and no biopsy proof, what would you say is his diagnosis and stage? Jen, are you conducting it or am I doing something?
We're conducting it.
Okay, good.
Nice. A couple seconds more.
No problem.
Okay. So there are the results.
Okay. I assume everyone can see that. So we can go to the next slide. So ultimately, he was deemed to have, again, clinical T4 given what was felt to be local evasion and advanced disease, and N1, as you saw, he had the lymphadenopathy. And then comes the question, and I think rightly so, you see the majority of our attendees trying to decide between M1B, implying bone-only disease, versus M1C, and the possibility that he has these distant metastases in the chest. And so because of a variety of, unfortunately, COVID-related issues and delays with being able to establish M1B versus M1C, and the need to get the patient immediately started with treatment, systemic therapy was given with the intent to follow the lung lesions and see what other additional workup might be needed later. So he started on docetaxel chemotherapy as well as degarelix, antagonist therapy, and then also converted to leuprolide. And the genetic testing that was done, unfortunately, did not reveal much that was of help here. So you can see here he was heterozygous for some of the mismatch repair genes and BRCA2 that might have led to some guidance on why his disease is so extensive. Of note, he was briefly hospitalized for COVID while on docetaxel chemotherapy and had some acute kidney injury that he presented with. And so in light of the above, and also a dramatic response that he had to chemotherapy in this meantime, he did stop docetaxel after 4 cycles. So next slide will show you, again, this is on the left, you're gonna see the initial disease that he presented with, as demonstrated here, significant adenopathy, and then on the right showing the tremendous response when the decision was made to stop his docetaxel chemotherapy. Next slide. And even more recently, again, all of the lesions shown here on the left from his initial imaging, and then on the right showing really impressive response thus far. So this is where things get complicated. And although this is a more dramatic presentation, I think you will find that there's an increasing number of these patients who do present to us. And so the questions I want to raise for discussion with the panel, and I think really are some of the most challenging for us, is when you see a patient like this who really truly is otherwise healthy, he's working, as I mentioned, he has hypertension, hyperlipidemia, but otherwise really in great shape, no evidence of bladder cancer, and at this point only carries a prostate cancer diagnosis and metastatic disease, but has presented and continues to present with issues of urinary obstruction. Would you give any RT? Would you wait and see if he responds more to other systemic therapy? Would you only offer radiation in the event that he needs it on a palliative basis due to pain or other symptoms? If you did give radiation, to what targets, and if more than one target, the sequence, the timing, the dose, and what about the systemic therapy? Would that continue alongside, and would you recommend any change in the systemic therapy? Meaning, after the COVID diagnosis, and he's actually since been fine and tested negative for COVID, would you resume the docetaxel given the response he's had? And in all of this, I would love for you guys to, think about and perhaps share what would be your intent. What's your goal of care here? And how would you actually counsel the patient on what your intentions are so that he knows and has realistic expectations? And are there any data to support your approach? So really, there's a ton to discuss here. And I'd love to, again, chat about this with our panelists and see their thoughts.
Well, I guess being a panelist, this is a very complicated case. It's interesting. I see a case like this several times a year at the University of Utah. It's always a dilemma. When you see such a dramatic response, you're kind of motivated to do more. It biases your impression of the patient. And to me, in terms of goal of care, I personally, think that if you're going to do some kind of local therapy here, to me, the goal of care, one would be maybe the palliative side. Men with very unusual and large and dramatic prostate presentations and obstruction, even when they're well controlled for a long time on systemic therapy, can often kind of progress down there in a way that was symptomatically. And we've had a culture of practice at our institution where actually the med-oncs routinely send me men with ugly looking primaries, even in the setting of metastatic disease, to irradiate them up front to sort of protect them almost prophylactically. So I'd be tempted to do that. And the radiation I would ascribe to the prostate gland, if I was going to do prostate only, we have a regimen of basically 45 gray and 12 fractions. It's not exactly a definitive dose, but it's been successful for us at preventing progression through the years. But to me, the more interesting question is, of course, the whole shebang. And this in a way rolls into my case, so I don't want to monopolize the conversation, but I will say that I think it is reasonable to do it, and I would like to hear what the others say.
Thank you. And also I'd love to know what you guys think about, the androgen deprivation therapy regimen, if you would weigh in on that as well.
Yeah, this is a tough case, Neha. You really set us up with a tough one here for a Friday afternoon.
Yeah.
You know, I thought you'd be rolling out some oligometastatic disease where we'd have a lot of data to point to about radiating the prostate and improving survival, but this is really a pretty data-free zone. And so even though my gut always with metastatic disease now is to try to radiate the prostate, given the great results from the Stampede RMH showing an improvement in overall survival, I don't think it can really apply to this patient with his very high volume disease. So I think personally, I would look at this as a more palliative situation where I would try to use systemic therapy to make sure that he can urinate okay. And if I were to radiate the prostate, it would really be if he's not able to urinate and he's, you know, we're losing local control.
Yeah, I think I look at it kind of similarly where, there's patients you think of who have oligometastatic disease or low metastatic burden is kind of the next tier. And this person doesn't fall into either one of those criteria, at least, based on how much disease he's got. And I would probably complete 6 cycles of docetaxel if he could tolerate it. And then if he's got any residual urinary symptoms, then I'd consider treating him, and I'd do something palliative. Probably would do something like 6th grade times 6 or 55 and 20. So something similar to what was used in Stampede that's not dose escalated. And then would actually honestly let him decide which option of those he'd want to. But again, it's only if he's got residual symptoms. If he doesn't have symptoms, then I think I would just continue systemic therapy.
Yeah.
I would say, for the sake of the discussion, that I would be tempted to, consolidate. But if I were to, let's say, go for broke and treat the nodes and all sites of disease, I'm a fan of Lupron plus abiraterone or a 2nd generation antiandrogen. It's extremely impressive. Our anecdotes at our institution of men on those combinations, they get similar to this docetaxel response, usually just remarkably good response to the drugs. And it's kind of borrowing from Stampede, which Dr. Nguyen was alluding to. You've got data from Stampede that helps you with control of primary. You also have data from Stampede and other studies that clearly show that 2nd generation antiandrogen and Lupron are beneficial. And then the question always ends up, for how long? And that could be a 1-hour discussion. But I would be tempted to give that patient at a minimum 6 months, but I like going 2 years on that with the combination, if you are going to look at it from a non-palliative approach.
Right. No, and this is really important, I think, for our attendees to note, as we do have these emerging data like Stampede, and then that temptation rolls in to try to apply it to patients that would have been clearly not included in that group. It's hard to not have the enthusiasm of the medical oncologist sending this patient, the patient who himself is highly motivated. And so again, getting back to the point here, this is a data-free zone, and truly, if it wasn't for the fact that this patient is even presenting to your clinic, historically, we didn't necessarily even see these patients except for the point at which they needed palliation. So I'm inclined, I agree with all that was shared. I'm always sort of debating, if I do Stampede style RT to the primary, do we treat the nodes? And then also, of course, the question of when, and should we just keep them on systemic therapy for a little bit longer and see? So I also don't want to the whole time spent on this case. I'll just ask one last question. I think I have one more slide, which is, imagine this patient, exact same patient, forget the chest disease. Let's just say he had all pelvic disease, had incredible, again, robust response, practically a complete response to docetaxel chemotherapy. And you never ended up giving the radiation, you're just observing and watching, comes back with this finding as the only current active site of disease other than his primary. I was just curious, among the panelists, would you still continue to ignore the primary or and just treat the bone, assuming this is now presenting as if it's a single oligomet, with the idea that those other metastases are only at the moment showing a response but aren't necessarily cured? Or would you treat the primary and this area, or would you still not treat and just continue systemic therapy, knowing the prior history? So again, not newly oligometastatic, but more sort of post-chemo oligometastatic.
So is this a residual site of disease? Is that what you mean? Or it's a site of?
We're pretending it's a different patient, but yes, I'm pretending,
Yeah.
let's just say that that's all he had now, plus an untreated primary and history of obstruction that comes and goes.
I think that if everywhere else he had a good response and this was the only site that wasn't responding, or even down the line was a single set of progression, I'd probably treat this. I probably would do SBRT to it.
I would do the same. I wouldn't treat the primary in this particular hypothetical case, because if we didn't treat the primary, we didn't treat the nodes. And philosophically, you either treat everything or you treat nothing is sort of my rule. But I think oligo progression deserves therapy. But in this scenario, the idea I think would be systemic therapy-free survival as an endpoint, like do this instead of systemic therapy. That would be the context with which I would do it.
I would agree. We'd probably do SBRT to this lesion if this was the one that was progressing or persistent after therapy.
Right. Thank you.
That was a wonderful discussion of the first case. I think we could spend an hour on it. But the next case is on bladder cancer, and I will hand it over to Dr. Solanki.
Great, thanks. So this next case is a 75-year-old gentleman who presented with a week of hematuria and severe lower urinary tract symptoms, primarily urgency and frequency. Has a lot of comorbidities, so coronary artery disease, atrial fibrillation, history of CHF, peripheral vascular disease, and pulmonary hypertension. But overall actually looks better than his chart would suggest when he comes in. So he ultimately had a cystoscopy, and on the cystoscopy, they identified a 6-centimeter mass that was arising in the trigone of the bladder and was including the right and the left lateral walls of the bladder as well. So kind of a larger sized mass involving a large part of the bladder. Had an incomplete resection with pathology suggesting muscle invasive urothelial carcinoma. At the same time of presentation, he had lab work that showed normal kidney function, blood count was okay. And he had a CT chest, abdomen, pelvis that only showed a large mass in the bladder without any extravesicular extension, no nodal involvement or any evidence of distant metastatic disease, and no hydronephrosis. So here's a image. I played with the window leveling when I submitted this, so you can kind of see the bladder tumor well there, kind of in the posterior aspect of the bladder. You can go to the next slide. So question number 1. So this gentleman has T2, N0, M0 urothelial carcinoma of the bladder. And so how would you treat this patient? What would be the recommendation that you would make if you saw him in your clinic? So I'll read through these. I know it's a lot of options, but I'll kind of summarize kind of what I'm trying to get at with each one of these. So the first option is radical cystoprostatectomy with either neoadjuvant or adjuvant chemotherapy. So primarily treat this surgically. Option number 2 is chemoradiotherapy, and the target would be the bladder and the pelvic lymph nodes. And you would use standard fractionation, so 40 to 45 gray to the nodes, and then a boost to about 64 gray to the bladder, or something similar to this. Option 3 is chemo-RT, targeting the bladder and the pelvic nodes, but you would use a hypofractionated regimen, so something that is around the order of 20 to 25 fractions. Chemo-RT just targeting the bladder and using conventional fractionation, so 64 to 64.8 gray. Chemo-RT just to the bladder using hypofractionation. Definitive radiation alone, or would you say this person has a lot of medical comorbidities, so let's take more of a palliative approach?
While we're waiting for the answers, let's just say you were going to take a palliative approach. I'd like to let people on the call know that there was a regimen of 3 fractions of 7 gray that is very effective for palliation of bladder cancer, and it was based on a randomized trial from the United Kingdom. So that would also be a reasonable fractionation pattern for somebody in the context where you wanted to palliate, as opposed to a 30 gray and 10.
Thanks, Jonathan. Yeah, that's exactly right. That's a good regimen. I've used it on occasion, but typically for this type of patient, I wouldn't do palliative RT.
I agree. It wouldn't be my choice here, but just for the record.
Yeah, right. Okay, so I'll maybe just talk through some of the results here. So 11% said they would suggest radical cystoprostatectomy. 33%, so the majority, would recommend chemo-RT using conventional fractionation and would treat the pelvic nodes and the bladder. 22% would do the same, but would use a hypofractionated regimen. No one would treat the bladder only with conventional fractionation. 30% would treat the bladder only with a hypofractionated regimen. And then few people would do definitive RT alone and palliative RT. So great, thanks. We'll go to the next slide. So I think there's some key learning things from this. And what I was trying to get at with these different options is that there's actually a lot of data available looking at the optimal way to treat bladder cancer patients, but a lot of unanswered questions. So, option number one was radical cystoprostatectomy, and there's no mature randomized data that are available. There was a trial called the SPARE trial in the UK that tried to randomize radical cystectomy with sequential chemo-RT, but unfortunately it failed to accrue. And there's a really good article if you're ever interested, looking into why it failed and the lessons learned and kind of exploring equipoise and how to set up trials, testing surgical versus radiation modalities, and how you can potentially be successful in that setting, because it's the same country that later would do the PROTECT trial successfully. I think the reason I brought it up is it's important for us as oncologists to discuss all the options. Many times, the patients that we see in a radiation oncology clinic, based on a survey that was done, seem to be those patients who are medically frail, who refuse cystectomy, or for some reason are just technically not good candidates. And so, frequently those are the patients that we see. But I think it's important for us to keep in mind that there isn't a clear best option for patients who have muscle-invasive bladder cancer. There's a ton of registry-based studies that are out there, and depending on who the authors are, either so surgery's better or that radiation's better. But in the end, I think there's two reasonable options from a big picture perspective. When it comes, nobody really said definitive radiation alone, which is good. I'm glad about it. But just to highlight that there's two randomized trials that compared radiation with concurrent chemotherapy, the NCI Canada trial, which used concurrent cisplatin, and the BC2001 trial, which is a little bit more modern, that used 5-FU and mitomycin C. And both of them had very similar findings, which is that chemo-RT improves local regional control, but doesn't improve survival, with the only caveat to being that BC2001 actually showed a metastasis-free survival benefit. And both of these studies were actually underpowered to test whether there was an improvement in survival. You can go to the next slide. So other key things that come up with the different options, so the target volume. So I think it's really interesting how the target volume that's used in the US versus internationally is kind of developed. So the majority of people invoked the classic RTOG regimen, which a lot of folks in the US use, which is about 40 to 45 gray using 1.8 to 2 gray per fraction, sometimes actually BID, to the whole pelvis. And historically it was a small pelvis, so going to the mid-sacrum, mid-SI joint, followed by a sequential boost to the prostate and bladder to about 54 gray, followed by a gross tumor boost to 64 gray. And in the UK, it actually developed as just treating the bladder only using 3D with some dose going to the perivesicular nodes. Interesting, there's actually a Pakistani randomized trial that compared bladder only with bladder plus elective nodal irradiation that showed no difference in local regional control. So the level 1 evidence actually suggests that there's not a clear benefit to treating the pelvic nodes. Our practice at our institution has been primarily to treat the bladder only, but in selective young healthy patients, we tend to treat the nodes. Unfortunately, that's not a large proportion of our patient population. I'll take a second here to ask the panelists what their practice is in terms of the target volume for T2N0 bladder cancer.
I used to always treat the old RTOG regimen, but then after the BC 2001 trial came out, as you said, I'll be just treating the bladder alone. We've shifted over, I would say, mainly to bladder only, given that that's what they did in that study.
Same here for our T2N0, that's exactly it. Since BCO2, that's what we follow, and also increasing use of hypofrac, just like you said at your practice.
And likewise, we would do bladder alone, 55 gray and 20 fractions with mitomycin C5-FU.
Do you guys use cisplatin concurrently with hypofractionation? I know that's the next topic that I have, but since you brought it up, have you had any concern about using cisplatin with a hypofractionated regimen?
I can't say we have done it. We kind of have an institutional bias since the James trial came out sort of with the Mito 5FU, and so really I don't have any experience with it, but intellectually I wouldn't have a problem with it. I'd be perfectly content doing 55 gray and 20, or with platinum, if that's what the medical oncologist thought was reasonable.
Yeah, we gemcitabine, cisplatin, or 5FU, mitomycin C, we actually don't let that adjust our dose fractionation. Actually, similarly, we are willing to treat the nodes too if we want to treat the nodes with any of those chemo regimens as well. So going to the dose fractionation, so there is actually multiple, I think I counted 8 randomized trials that are historic from the 2D era that compared conventional fractionation to 64 gray with moderate hypofractionation that established the 55 and 20 that was used as an option in BC 2001. That showed that they were similar. So actually the level 1 data supports that moderate hypofractionation is a reasonable option for bladder cancer, again, when treating the bladder only. There's a recent pooled analysis of the Beacon trial and the BC 2001 trial that was presented at ASTRO last year, and I don't believe is published yet, that showed that there were similar outcomes or better when using moderate hypofractionation with compared to conventional fractionation when treating the bladder only. There's less data for hypofractionation when treating the bladder and the pelvic nodes, but on occasion we've done that as well, just because it's similar principles to other pelvic malignancies. So our typical practice is to use conventional fractionation, but I have to say we're shifting more towards hypofractionation in this setting.
For interest of time, maybe we can have the panelists discuss the next couple of poll questions. Is that okay?
Yeah, and that sounds good. So what would you guys do? Would you do 3D or IMRT if you're treating the bladder only?
Well, maybe I'll jump in real quick. We have kind of a complicated process, but to be brief, we sim with bladder empty and bladder full, but we actually develop 3 treatment plans. One bladder empty, one bladder full, and one with a made up volume in the middle. It is an IMRT plan that we'll deliver, and we choose the plan of the day based on the bladder fill at the time of sim. Very labor intensive, not very practical for most clinics. But what we're trying to do is always cover the bladder with the smallest field possible.
We follow the exact same approach and also do IMRT, although as you know from, you may have seen at the Astro ARS talk on the Wednesday of Astro that either really is appropriate and supported by the data.
Questions coming in from our audience asking about treating partial versus full bladder for the boost when you're doing conventional fractionation.
So there was actually a 2x2 randomization in that James study that compared either a concurrent chemo or RT alone, and then also kind of partial bladder de-escalation. So doing kind of an SIB to the gross tumor that actually showed no difference in toxicity. And so I think it's either way is okay. I think what I've typically done is if I can really identify the tumor well, sometimes we'll have our urologist put Lipiodol into the tumor bed to help us to identify where it is. If I can really confidently identify where the tumor is, then I'll do just a lower dose to the whole bladder and then a boost to the gross tumor. But I find that in most cases, I end up just treating the whole bladder to full dose.
Yeah, same here. I wind up, when I used to try to cone down, once you put on a 2 centimeter expansion to account for bladder motion, you wind up treating the whole bladder anyway. So exactly as as Avi was saying, I wind up treating the whole bladder most of the time now.
And I think that's a good segue into the last point about this part of the case that I wanted to bring up, which is that there's an ongoing trial, the SWOG Energy 1806 trial, that is potentially a look into the future, I think in a couple of ways. So similar to many other trials that are ongoing in bladder cancer, it's testing the role of concurrent and adjuvant atezolizumab. But I think for those of you who maybe studying for tests or just want to learn kind of options for how best to treat these patients, it's a good resource because it has very detailed descriptions of target delineation, dose constraints, things like that. So seek that out if you would like to learn more about kind of the nuances of treatment planning. So I'm going to just shift very quickly. And that was actually not the actual presentation that I just presented. The actual presentation was the person was just as sick. The TURBT and the cystoscopy looked the same, but he actually had significant kidney dysfunction. His GFR was 30, and he had 2 pelvic nodes that were positive, and he had terrible bilateral hydronephrosis. So this was the actual patient. So we'll go to the next slide. Here's an example of the hydroureter on both sides, as well as two of the lymph nodes that were positive. So we placed bilateral nephrostomy tubes. Now what? What would you do? How would you treat this patient?
We have great trials for these men.
While we're waiting on the result, Jonathan, maybe you can talk a little bit about the trials that you have.
Some are institutional. Like our enthusiasm right now is we have a trial where we definitively do chemoradiotherapy, actually followed by immunotherapy, with checkpoint inhibitors. There's a lot of enthusiasm for that, kind of like the atezo. I didn't, if it were up to me, I would have designed for some concurrent checkpoint inhibitor with the radiation, but that's not how it was designed. But I would support that kind of approach. I think these patients need trials, quite frankly.
Yeah, I agree with you. And then I'll talk about a trial that's ongoing currently in a couple of slides. So most people, about 2/3 of people, would do either chemo-RT to the bladder and nodes or some sort of neoadjuvant chemotherapy, followed by consolidative local therapy, either with surgery or chemo-RT. And what we found is that most people do say those final two options. Do any of the other panelists have any other comments on that, other than I think that seems to be what a lot of centers do?
Yes,
Good.
agreed.
So this is the actual treatment plan that we used. So we ended up doing a sequential boost. So we did 45 gray to the pelvis, 54 gray to the whole bladder and prostate, and then we boosted the bladder and the gross nodes to about 64.8 gray using conventional fractionation. I think we did sequential. You could easily do SIB as well, and I think that's a reasonable option. We'll go to the next slide. So this is actually a trial that is ongoing, the ECOG Energy 8185 trial. So this is for specifically node positive non-metastatic patients, and it's patients undergo induction chemotherapy for 3 or more cycles and are randomized to either chemo-RT alone or with durvalumab. They undergo restaging, and the primary endpoint is clinical complete response. And then based on that response, they either continue observation in the control arm and durvalumab in the experimental arm, or they proceed to the next line of systemic therapy or salvage cystectomy if they have local disease alone. So this also is a good resource if you're looking for radiation treatment planning details and things like that to help guide you. And with that, I think that's it for the bladder case. Yep. Thank you.
Thank you. For time, we are going to keep going, but we will have to speed it up a little bit.
I'll move quickly. So this is a 71-year-old, very healthy man, had a routine PSA 6.8, the standard story, T1C disease. Biopsy was basically low volume, Gleason 3+4. He has excellent urologic function, okay sexual function. You can see the PSA trends, the doubling time over the past few years was nothing that fascinating. We would have thought he was a garden variety prostate cancer patient. There's nothing about the past medical history or family history that's really significant. And here you can see the images. We got, multi-parametric MRI. Hopefully it projects well, but there's a pretty sizable lesion you can see on the T2 there on the right side of the gland with large capsular abutment. And as our radiologists always do, they talk about, concerning for extracapsular extension. And you can see, maybe it doesn't project very well. It was sort of corroborated by the diffusion weighted image. So they gave that a PIRADS 5, highly suspicious. Next slide, please. Here was the surprising finding on the imaging. The sagittal view on the left was very hard to understand. I kept staring at it and we couldn't figure out what we were staring at. And what that is it's what was called large volume ascites above the bladder. And then the other surprise with such a boring presentation otherwise was a lesion in the left pubic ramus that the radiologist was very sure represented a metastasis. So if you look at the bone scan that was also then obtained, it corroborated that little bone met you can see there on the PA, and it was considered a solitary bone met. So we were left with an oligometastatic presentation with this curveball, and what the curveball was pseudomyxoma peritonei, which is, you know, a relatively unusual diagnosis. And for those who are unfamiliar with it, it's this sort of weird, massive mucousy presentation that kind of packs in through the retroperitoneum. And a lot of people have this, don't even know they have it. This man was basically asymptomatic, but you can see how you might manage it. So this was managed with this dramatic exploratory laparotomy, appendectomy, cholecystectomy, splenectomy, omentectomy, and yada, yada, yada. Oh, and by the way, after that, we infused him with mitomycin C5FU with HIPEC. I wasn't part of this decision-making, by the way. The patient didn't come to me prior to all this. The patient came to me after this. So before I actually laid eyes on this patient, I thought, oh my God, what's going to walk into my clinic? I was expecting to see some kind of really whipped, frail guy, but what I saw was a completely vigorous, healthy man who did just amazing after the surgery, who actually recovered beautifully and felt normal. So now what? Let's ask the panelists, how are we going to treat his oligometastatic disease? And I think feel free to comment while the people are voting.
So I think with the, you know, the image of the patient that you described, despite the somewhat scary procedure that he underwent, it is very tempting to want to do exactly, you know, something similar to what we talked about for the hypothetical scenario in patient one, which is to give the benefit of the doubt, to be aggressive. My tendency is, if I think I can do it safely and the patient understands the goals of care and doesn't have expectations that are unrealistic, and that I haven't given those expectations unrealistically, then I do try to be as aggressive as the patient wants to be. And I think, to your point earlier, Jonathan, is, you know, are you looking for systemic free survival? What is the patient ultimately after?
Very
and
important.
that usually guides me as well.
Dr. Nguyen, any thoughts?
Yeah, I would agree. I think I tend to try to be aggressive. You know, if this is a healthy patient otherwise, and he's got oligometastatic prostate cancer, I would be aggressive with the radiation and also systemic therapy potentially for him.
Abby?
Yeah, I agree. I mean, the two settings in which radiation has improved survival is in limited metastatic disease and high-risk disease. So, you know, I'd offer it to him.
So in the interest of time, because I'm sure whatever Dr. Nguyen has to say is far more interesting than what I have to say, I will let you guys go through the poll. But let me tell you, the patient's goals really did rule the day here, which I think is is the most important thing we have to find out. And interestingly enough, when I talked to him about different options, one of his highest priorities was actually to not be put on hormone therapy, which of course is an important discussion. And so I think it's reasonable to agree to that. And so if we go to the next slide, actually, what you can see, what I decided to do in this case with the goal of systemic therapy-free survival specifically, was to do SBRT to the prostate alone plus SBRT to the single bone oligomet. And I used the fractionation, just 36, 25, and 5 fractions, which is, you know, what you might choose to treat the primary prostate at. And looks like we got the poll in on what you would do. Of course, I didn't reveal the patient didn't want systemic therapy. I struggle with these patients in terms of, it's just like the first case. Do you do the nodes or not? The reason I liked this case for this conference was I was shy about going in and doing nodal radiation after all the things that had happened to him, especially given his primary goal was maintain quality of life. You know, he understood that what we were doing is probably not curative in nature, and I felt that it was comfortable to eliminate nodal radiation here. What about my colleagues? And again, I won't do many more minutes on this, but anything else that should be commented on at the moment? Looks like no. Next slide, please, because it gets interesting. I had a slide that showed the Stampede trial and the HORAD trial, which we touched on earlier, but you know, some of the rationale for treating the primary comes from Low Volume Disease and Stampede, and I encourage people on the call to read that one. There was another trial, HORAD, that also looked at a similar setting, although it wasn't, you know, so much a low volume thing, where they showed this endpoint of hormone therapy free survival on HORAD. So I'm sorry, not on HORAD. They didn't show a benefit on the HORAD trial to irradiating the primary, but they didn't look at the subset. I think if you have a low volume patient, then those who we know clearly benefit. And there are two other trials worth mentioning that don't fit this context exactly, but you have the Oriole trial and the STOMP trial, which separately did something different, which is in patients previously treated with curative intent. When they developed oligometastasis later, they looked at radiation therapy versus observation. Now, in a way, that's kind of funny because we don't generally observe patients with metastatic disease. So what we can say from these trials is radiating tumors is better than doing nothing. But I think that the data is compelling in that you can get some pretty durable biochemical progression-free survivals, and would encourage you all to see Oriole study as well as the STOMP trial from these slides. So let's just go to the last slide. The next one, please. What happened to him? Well, you can see I actually irradiated him. I think I completed it in October of 2019. He got a PSA response. It dropped to 1.2. Then it started rising again. And in August, it was 3.72. We got a regular bone scan. I could have and usually would get something like a fluciclovine or PSMA, but what the bone scan showed was a new oligocyte matching exactly on the other side. So he developed an ischial lesion on the other side. And during my CT sim, it looked like there were actually 2 lesions there. So we bought him 1 year so far of hormone therapy-free survival, excellent quality of life. I am now irradiating the other 2 sites. I'm going to keep my fingers crossed, and we're taking the whack-a-mole approach. And because I want to make sure Dr. Nguyen has lots of time, I think I will stop there.
Thank you. We'll hand it over. Sorry to rush you all. To stay on track, Dr. Nguyen.
Awesome. Yeah. Well, thanks again. Maybe what I'll do, since we only have 9 minutes left, is I'll just try to give some of the take homes that I want to talk about here. We're going to present, my colleagues presented the most interesting cases, and I'm so in awe at the kinds of cases they presented. This is a very run-of-the-mill case. This is just a standard high-risk prostate cancer case. But I think that the 2 points I just want to leave our medical students with is that radiation and surgery are equivalent in terms of outcome, survival, control for these kinds of diseases. And that's really important because when you walk into clinic, you don't really know, and people will sometimes tell you, oh, surgery is better than radiation, this and that. But we have really strong data, I think, that surgery and radiation have the same outcomes. And the other thing I want people to be mindful of is just that who we think of as older may actually live a long time. And we have to be careful when we think about, which patients are we going to treat and not treat. So this is a 74-year-old man with a PSA of 17. He's got a biopsy Gleason 8 in 7 out of 12 cores. He's got extracapsular extension at the right posterior lateral base. So this is a classic high-risk prostate cancer case. Here you see the NCCN guidelines, which basically say for anyone over over a 5-year life expectancy, we want to treat them. And we can treat them with radiation and hormones. Here they say 18 to 36 months, or we can treat them with surgery, possibly with radiation and hormones afterwards. Next slide, please. So we know that from various studies that long course hormones is better than short course hormones for these patients with high risk disease. So generally we're talking about longer course I would treat with about 24 months, although there's some discussion about treating with 18. Next slide, please. And we know that adding radiation improves survival compared to just using hormones alone. Next slide. And I also like to use a brachytherapy boost for these patients. If we had more time, we could discuss this more, but basically you can see on the next slide that adding a brachytherapy boost reduces the risk of recurrence by 50% for these patients. It hasn't yet improved metastasis or overall survival, but I do feel that for especially these high-risk patients, the magnitude of the benefit on progression-free survival is pretty big and should be used. Next slide, please, and next slide. And we'll keep going. Thanks, sorry about that. So 24 months of hormones, I use 50.4 gray of radiation and a brachytherapy boost. Next slide, please. So how does high quality surgery compare to radiation? Well, see, the surgeons all have this meta-analysis that when they looked at the old data, they found that those who got radiation always died more than those who got surgery. They had more prostate cancer death and more overall death. But the problem with this is it's a little bit garbage in, garbage out. These are retrospective patients. A lot of the radiation was just either radiation alone, wasn't enough hormones. And we know that the patients that get picked for radiation tend to be worse off. So when you just compare their outcome to those who get picked for surgery, of course they're going to look worse. And that's what the data showed. And I think that, you know, we sort of got this lorded over us for a long time. If you go to the next slide, please.
Dr. Nguyen, can I interrupt you to ask a question of the panelists?
Oh, yes, Dr. Fields, of course.
I'm wondering, well, Jenna asked this in the chat, but we're wondering who of the panelists regularly offer a brachy boost for these patients?
Every time.
Yep. And I just answered as well. We do it for
good, thank
nearly
you.
all of our patients. Yep.
We discuss it for most. I actually did a lot more brachy boost in the past. We do primarily HDR. I kind of discussed the pros and the cons, what the Ascend RT study showed, what the 2 prior HDR randomized trials showed. And usually we reserve it for the younger, healthier folks, especially those who have high volume disease. So SVI, EC, big bulky tumors, those patients, we definitely try to, push towards doing brachytherapy. As everybody said, I think we discuss it with everyone.
Awesome. So I wanted to just show everyone this retrospective data. Yes, it's retrospective, but I think it counteracts the narrative that when you look at retrospective data, surgery is always better than radiation. This was in JAMA, and it looked at when you do proper radiation plus hormones plus brachy boost. Can we do the next slide, please? And next slide. It appeared that adding the brachytherapy boost with radiation and hormones was at least as good as surgery and maybe even better. Now, of course, it's retrospective, so we can't use it as gold, but you just have to know there's this other competing narrative out there that suggests that things could be just as good. And why don't we skip through the next few slides? We can skip this one. And there's one randomized trial out there that I think everyone should know about. It doesn't get enough credit. It was a randomized trial of radiation, hormones, and brachy boost versus surgery. And can we do the next slide, please? And even though it was a very small trial, only 89 patients, it didn't show any difference in prostate cancer specific mortality. So it completely goes against this narrative from the surgical retrospective data suggesting that you have twice as high a risk of death with radiation than with surgery. So I want everyone to keep this in mind. When you walk into clinic, you should feel confident offering your radiation and hormones and perhaps with the brachytherapy boost. You're offering patients something that gives exactly the same survival. And then can we do the next slide? Okay, perfect. So now, last thing I just want to talk about, what happens if somebody's 85 years old and walks into your clinic with the exact same situation? I think often we think, oh, they're 85, we shouldn't be pushing too hard. But just remember that they can still have a lot of life in them. Can we do the next slide, please? And then next slide. So you determine life expectancy based on Social Security tables. If you just think to yourself, at what age does a man have a 20-year life expectancy? That's 62. 10-year life expectancy at 77, and you still have a 5-year life expectancy at 87. So unless somebody is over 87 walking into your clinic or they have a lot of comorbidities, if they've got high-risk disease, you should still be thinking of offering definitive treatment for these patients. So just want everyone to keep that in mind. I know we've still got 3 minutes, so I just want to turn over my time, make sure that our host can wrap up.
Paul, I just want to say with life expectancy, it's a fascinating thing. There are 2 validated indices, one called the Lee Index and one called the Schonberg Index. These aren't very well known. I've never seen it in a rad-onc curriculum, but if you Google Lee Schonberg Index, which I put, I think, in the chat, you'll find a website called, I think it's called ePrognosis, that'll let you put in the parameters. It's an extremely validated life expectancy estimator that uses basically ADLs, IADLs, age, and other things. And so I would encourage people to look into that. I use it all the time in my clinic. It's extremely helpful.
Very cool.
I had my own question that I put up here. In the new NCCN guidelines, they now allow for high-risk prostate cancer. You can do prostate SBRT. Are any of you doing that?
We're not.
We do in select cases. I mean, but it goes back to the goals of the patient. Again, you know, it's not a preferred option for us, but you know, patients, especially coming from far away, we have a referral base from, you know, half of America in Utah. So it's pretty common for us to get people, Idaho, Montana, Wyoming, farmers, ranchers. They can't deal with 2 months of RT. It's a very good option in circumstances like that with hormone.
Yeah, we're similar. At our VA clinic, we have a lot of patients who have a lot of social barriers that stop them from coming, and that may be the only way that they can get treatment. So I've definitely given SBRT to high-risk patients.
Okay, well, great. Thank you so much. We are wrapping up just in time. So thank you again to all of our panelists, our coordinator, Navjot. We'll be sending out a post survey following the session. So please fill it out and then can visit our website for our next session. So in December next month, we'll have our CNS panel. So thank you again, everyone, for participating.
Thanks for having us.
Thank you.
Thank you, everyone.
Nice to see everyone.
Have a great weekend, everyone.